Medicare Advantage costs the taxpayer more. Taxpayer spending for the average enrollee in Advantage is supposed to be the same or less than what the spending would have been if that enrollee was in Traditional. This has not come to pass, despite one of the main selling points of Medicare Advantage being that it will help the deficit and debt by saving the government money on Medicare. Advantage has cost more than Traditional every year for a similar beneficiary. Medicare Advantage is increasing the speed at which the Medicare Trust Fund runs out. Advantage costs more primarily because the government simply gives Advantage too much money. The government has been trying to get this right for over 20 years, but for-profit insurance companies have been better at gaming the system and therefore ripping off the American taxpayer than the government has been at cracking down. Some of this is due to private businesses being more flexible than bureaucrats. Some of it is caused by powerful and big money-backed lobbyists. Some is caused by Republican ideology that biases them toward anything they can call the private sector. And some is caused by the difficulty of Congress doing anything that can be demagogued as a cut to Medicare. The causes of the overpayments to Advantage plans are favorable selection, how risk scores are coded, quality bonuses, the way county bonuses are calculated, not factoring in Medigap, and Advantage companies cheating the system by vertical integration. Favorable selection. Advantage plans have favorable selection. On balance, healthier people join Advantage plans compared to traditional Medicare, making the Advantage pool of people less costly to insure. Studies have used alternative methods to judge the health of a patient and found that Advantage enrollees are healthier than traditional enrollees. A study looked at data from the National Health Interview Survey from 1997 to 2005 and linked it to 2000 through 2009 Medicare enrollment data to find that the greatest increase in enrollment into Medicare Advantage was from those with no chronic conditions and men. Advantage plans recruited healthier enrollees by three general mechanisms. 1. In an effort to be efficient and save money, Advantage plans create restrictions that are more harmful to more unhealthy people than healthy people, causing the unhealthy to be less likely to join Advantage plans. 2. Advantage plans can purposely design their benefits to attract healthier people and repel unhealthy people. 3. Advantage plans can specifically target healthier people with marketing and selling efforts. Advantage plans build limited networks, frequently require prior authorizations before medical care is implemented, and have other denial tools. They do this to limit overpriced and unnecessary medical care. Enrollees who actually need to use their insurance a lot because they're sick will more often have to deal with these burdensome obstacles to medical care. Healthier patients may care less about the coverage and more about low premiums and additional benefits. So, unless those obstacles happen to not be a problem for a particular unhealthy person, they may choose traditional to avoid these Advantage difficulties, while a healthy person is more likely to overlook them, making the Advantage pool healthier and less costly. Plans tend to not support medical care for diseases that would ruin plan profitability, which incentivizes the most costly patients to join traditional Medicare. Medicare Advantage organizations can intentionally limit their network's access away from comprehensive cancer centers, which make Advantage a worse choice for cancer patients with complex and expensive needs. Advantage plans also use the tactic of putting medications very sick people need into the highest drug benefit tier, which makes these patients have high out-of-pocket costs. Advantage plans can offer benefits like gym memberships, which are most attractive to healthier people who can regularly use the gym. Insurers can target their advertising to try to reach people who don't use insurance often, aka the most profitable people. Such ads show active, healthy people. Individual agents who sell Advantage target people who are younger and healthier. They sometimes target people they know personally or who they meet in their social gatherings like at church. Insurers have even been accused of holding enrollment seminars in buildings not accessible by wheelchair in order to discourage less healthy people from signing up for their plans. The government implemented risk scores to correct for favorable selection, but insurers can cherry-pick people within their risk score. Of Medicare enrollees with congestive heart failure, those within the top 5% worst health are 322 times costlier than those with the 5% best health. So, Advantage plans moved from cherry-picking in general to cherry-picking within risk scores. We don't know how all the cherry picking is done. Some mechanisms are trade secrets. Known strategies include withdrawing from unprofitable counties, offering free fitness club memberships, creating networks that don't include doctors and facilities needed for expensive ailments, making expensive medications only available with high out-of-pocket expenses, and hassling patients and physicians with prior authorizations. So essentially, the same methods that created favorable selection in general create favorable selection within risk score. An American Economic Review study suggested that insurance companies look for the cheapest patients who have risks included rather than just the cheapest patients. The companies can maximize their profits by acquiring enrollees who gain them a lot of federal money due to their listed conditions, but don't actually use a lot of care to deal with those conditions. Risk score coding. To address the problem of favorable selection, the government implemented risk scores. With a risk score, the more conditions a person has, the more the insurer gets paid from the government. Rather than fixed selection, risk scores created their own problem whereby Advantage plans get overpaid at the taxpayer's expense. The list of conditions that produce risk are created by the insurance companies. For-profit insurance companies have the incentive to list every possible condition to maximize the risk-adjusted payout, while traditional Medicare does not have this incentive. So, the same person in Advantage will be listed as having more conditions than the same person in traditional, increasing the payment to the insurer. Some of the conditions listed may be irrelevant to the cost to care for them. Insurance companies use the following strategies for inflating risk scores: providing incentives for providers to code diagnoses, adding diagnoses irrelevant to treatment, historical information searches, chart reviews, health risk assessments, and recording fake diagnoses. Insurance companies will actually pay a doctor more per diagnosis they record. While this seems unlikely to affect a code for an obvious ailment that needs treatment, it may induce doctors to code more minor diagnoses than they otherwise would. Advantage plans will use enrollees' historical information like electronic health records, claims, and risk score data to identify potential diagnoses, then get a formal diagnosis by ways like sharing such information with doctors. Chart reviews are the insurance company going through records of the patient's previous encounters with providers and recording any possible diagnoses. Traditional Medicare does not use chart reviews to get diagnoses. Advantage plans have gotten huge returns on investments by doing chart reviews. They have been accused of ignoring chart information that would disconfirm previous diagnoses, and have chosen to do chart reviews on people that are more likely to have more diagnoses found in their charts. Some plans call enrollees and give incentives for them to participate in health risk assessments. Insurers even send nurses to enrollees' homes to do risk assessments. These are conversations with someone like a nurse to fish for diagnoses to record. A study using 2019 Advantage data found that 44.4% of Advantage enrollees had at least one assessment. Of those that had at least one, their risk scores increased 12.8% from the assessment. More than 1/5 of enrollees had one or more diagnoses added by an assessment. Limiting the increase of risk scores from these assessments could have saved $4.5 to $12.3 billion in 2020 Medicare spending. A September 2021 Office of Inspector General study found that 20 of 162 Advantage companies got a disproportionate share of their payments from diagnoses only in chart reviews and health risk assessments, suggesting that they were using these to fish for diagnoses, which pumps up their payments from the taxpayers. Insurance companies may even be illegally upcoding. A New York Times article exposed insurers recording fake diagnoses to get more money from the taxpayer. Legislation and the Biden administration have tried to fix the issue. Whistleblowers have accused Advantage plans of purposely upcoding the degree of patients' conditions. Of the top 10 insurers, only one has not been accused of overbilling the government. Humana reached a settlement in 2018, and other cases are ongoing. Cigna paid $172 million due to allegations of submitting false codes. New York-based Independent Health agreed to pay $100 million due to accusations of inflating risk scores. According to federal audits, 8 of the top 10 Advantage plans have overbilled. 5 have been accused of fraud by a whistleblower, while 6 have been accused of fraud by the government. For 2022, Advantage overbilling was estimated to be between 88 and 140 billion. Overbilling here is falsely upcoding, so not just finding legitimate diagnoses that wouldn't be recorded in traditional Medicare, but exaggerating or making them up. The government has been getting more serious about cracking down on fraud in both traditional and Advantage, but it's hard to keep up with insurance companies who have the incentive to bend or break the rules, and it's hard to maintain the government's focus when new presidential administrations may for some reason not agree with such a focus. A 2015 paper found that Advantage plans code 616% higher than the same person in traditional. In 2019, the government used a 5.9% adjustment to account for Advantage upcoding. But, while accounting for only age and sex, Advantage risk scores were 9.1% higher, and for a person with similar healthcare usage, the average risk score in Advantage was 20% higher than it would have been in traditional, and Advantage risk scores have been growing, making the adjustment even more off. The adjustment was made 3.4% in 2010 and changed to the 5.9 number in 2018. The number has not kept up with the level of upcoding. In 2024, risk score inflation was again estimated to be 20%. At any particular risk score, Advantage enrollees have less spending than those of traditional Medicare. This supports that the risk scores are not accurately measuring risk when comparing the scores between traditional and Advantage. Upcoding, by making patients appear sicker than they are, also makes it more difficult or impossible for people currently in Advantage to buy Medigap plans if they switch to traditional, trapping them in Medicare Advantage. Some Advantage enrollees have said they feel trapped for this reason. Insurance companies can hire risk assessment companies to evaluate a person's risk, but large health insurance companies that participate in Advantage also own risk assessment companies. So those doing the assessments are not neutral third parties, but a part of the organization that benefits from maximizing codes. Quality bonuses. Advantage plans also get quality bonuses based on a star rating system. It's difficult to determine which Advantage plans are high quality and which are not. So the star method is far from perfect. There is limited data, flawed sampling, and score inflation. In 2023, the average plan was rated 4.15 out of 5 stars. Over half of plans were rated 4 or higher. These bonuses boost spending above traditional Medicare levels. Unlike other rebates that have to be used to reduce premiums or increase benefits, quality bonuses can be used for profits. A 2021 study compared Advantage plans to commercial plans before and after Advantage quality bonuses were implemented, and did not find a general improvement of quality based on the treatment of the bonus program. Several studies find problems with the quality ratings of Advantage plans, finding that these ratings often don't match other measures of quality. County issues. Advantage plans also get extra money from county adjustments. Without these bonuses, low-spending counties may not create an Advantage payment high enough to incentivize Advantage plans to offer coverage in these counties. These bonuses were made to counteract that. One way plans get overpaid is by shifting the balance of their enrollments toward counties where they get overpaid. Regression analysis using 2015 data from HMO and local PPO plans, after controlling for market and plan factors, found that counties with higher benchmarks have Advantage plans with higher plan costs and higher rebates, concluding that the current system may let plans bid higher than needed based on local input costs and other market circumstances. County bonuses were motivated to help Advantage plans enter counties with low traditional Medicare spending. Now, though, a majority of Medicare beneficiaries are enrolled in Advantage, so this incentive may not be needed, and is yet another thing that makes Medicare Advantage more expensive. Additionally, if Advantage insurers can't offer plans in these counties without getting extra handouts from the taxpayer, then maybe these counties shouldn't have Advantage plans. Traditional will still be there, and if Advantage plans aren't efficient enough to make a profit in such counties, then bonuses turn these plans into taxpayer moochers, not viable private plans. Not factoring in Medigap. Another source of Medicare Advantage overpayment results from the benchmarks being based on overall traditional Medicare spending. Many traditional Medicare enrollees have Medigap plans that cover much of their out-of-pocket costs. This leads to some level of induced spending because they don't have to pay for much of it. This means those with traditional Medicare and a Medigap policy look more expensive than they would be in a Medicare Advantage plan where they have a higher deductible and more out-of-pocket costs. Because the benchmark for Advantage includes spending that happens because enrollees have hefty supplemental coverage that costs them extra, really, Advantage is benchmarked against traditional Medicare and supplemental coverage. In traditional Medicare, the government is not paying for that supplemental coverage, but Advantage gets paid for the expected use of its beneficiaries, including use that is only used because beneficiaries are paying extra for a supplemental policy. The payment to Advantage should really be based on those without a private supplemental policy because their costs are not biased by spending induced by a privately paid for premium. Including people with Medigap policies in the benchmark for paying Advantage plans creates yet another source of overpayment to Medicare Advantage. Cheating the system with vertical integration. Since 2014, Medicare Advantage plans have had a medical loss ratio of 85% or higher, meaning costs from administration and profit cannot be higher than 50% of total revenues from premiums and government payments. So 85% of income from premiums and most government payments must be used to pay for medical care. Medical loss ratio requirements are not fully effective. Insurance can falsely represent business expenses and profit as clinical spending. Through transfer pricing, insurance companies can get around that 15% limit. When an insurance company owns certain providers and middlemen, it is selling things to itself. And because they are really the same company, these sales are actually just transfers, and the prices can be raised to make it look like the insurance company is spending more on patients, but really it is paying a marked up price to itself. This allows the insurance company to break the 85% rule. Additionally, this incentivizes lower quality providers to have higher prices because the prices don't represent quality care, but greater profits for the insurance company. Large health insurance companies are owning risk management companies, pharmacy benefit managers, vision and hearing companies, doctors' offices, and home health agencies. This gives insurance companies opportunities to increase profits without providing better health care. Similar incentives don't exist in traditional Medicare. The extent of the overpayment. Advantage was supposed to cost the taxpayer less per similar person compared to traditional, but it has cost more. The Medicare Payment Advisory Commission, MedPAC, is an agency created by Congress to advise on Medicare. They estimate that in 2024, for similar beneficiaries, Advantage was overpaid relative to traditional by 22%. 13 of these percentage points were from coding and 9 were from selection. Since 2007, this total has ranged from 9 to 22%. The coding piece has ranged from 1 to 13, with its highest years being recently, and selection has ranged from 4 to 13. Despite one of the main points to Advantage being to save the government money, and despite attempts to fix these problems, Advantage has consistently cost the taxpayer more than traditional. Overpayment and selection problems have been around for decades. Different reforms have attempted to fix these problems, but successes were incomplete. Two major things Medicare tried in the 2000s was limiting when someone can switch between Advantage and traditional and basing the payment on diagnosed ailments so that if less sick people join Advantage, those plans get paid less. Limiting the time people could switch helps, but people still switch for the purpose of using traditional's broader network. Basing payments on diagnosed health issues helped at first, but insurance companies soon learned how to game the system and more intensely search for diagnoses to record compared to traditional Medicare. So ultimately, this reform has been a failure. MedPAC estimates that for 2024, quality and county bonuses increased the benchmarks by 8%. A USC Schaefer Center study, after applying risk adjustment, found favorable selection to cause 14% higher spending. By the estimates of the physicians for a national health program, and based on 2022 spending, Medicare Advantage overcharges the government by 22 to 35%. The Center for American Progress estimates that 2024 Advantage overpayments were between 22 and 39%. That 22% is mostly from risk coding and selection bias. To get to a 39% overpayment, that estimate includes quality bonuses, county adjustments, and how supplemental coverage affects traditional Medicare benchmarks. Quality bonuses and county adjustments together add a 5% overpayment, and the supplemental coverage effect adds 12%. For 2024, that 22 to 39% overpayment is a cost of $83 to $127 billion. Overpayments to Advantage plans increase Part B premiums for everyone. Advantage overpayments increase Part B premiums and deductibles for people in traditional because Part B premiums and deductibles are calculated by the cost of total Part B spending, including the overpayments to Advantage. That's outrageous. Not only are Advantage plans ripping off the taxpayer, they are doubly ripping off those on traditional Medicare by making them pay for the overpayments to Advantage in their premiums and deductibles. Margins. Compared to the gross profit margins of the individual health insurance market, the group market, and Medicare managed care, the gross profit margins of Medicare Advantage plans have been over twice as high. Is there an actual good reason that Medicare Advantage plans should be more profitable compared to Medicaid, group insurance, or individual insurance? It seems that it isn't more profitable for good economic reasons, but because insurance companies are able to game the Medicare Advantage system. In 2022, annual earnings per Advantage member were $526. That was 45% higher than risk-based commercial plans. Advantage plans' profits typically run a little over 4%. Some had over 20% margins, but the ACA's medical loss ratio requirement that caps administrative costs and profits at 15% prevents that. The administrative costs are usually about 10% with 4.5% profit. Big insurance companies make tons of money from Advantage because their plans have a lot of people in them, so even without super high profit margins compared to some other industries, their total profits are large. Their margins are also misleading because big companies get high profits. This allows them to get around the medical loss requirements that require 85% of revenue paid out for Medicare services. They buy certain providers and can adjust prices so they are spending more money on medical services, but because they own the medical service company, that is still profit to them. The higher prices make it falsely look like more or higher quality medical services are happening than in reality.